ಊಟ ತಗೋತೀನಿ.
Hemophilia is a rare genetic bleeding disorder where the blood doesn't clot properly due to missing or deficient clotting factors. It primarily affects males, though females can be carriers and symptomatic. Early diagnosis, treatment access, and awareness are vital for effective management, improving quality of life, and ensuring equitable care for all. World Hemophilia Day is observed on 17th April to raise awareness about hemophilia and other inherited bleeding disorders. Welcome to this fourth edition of National Virtual Forum on Hemophilia Care, making hemophilia treatment equitable, access, affordability, and policy dialogue, organized by Voice of Healthcare with associate partner Roche and supported by Priya Medical Technologies and SUT Patna Hospital. This year, we focus on access for all, women and girls, lead to, emphasizing equity, awareness, and inclusive care. Together, let's champion comprehensive access and support for every individual living with bleeding disorders. I'm delighted to introduce my speakers for this panel today. Dr. Saloni Sadana, Mission Director, Department, uh, Health and Family Welfare, Government of Madhya Pradesh, as a keynote speaker. Welcome, Dr. Saloni. Dr. Uttam Desai, Member Secretary, Chief Medical Officer, and Nodal Officer for Quality Assurance Cell, State Family Welfare Bureau, Directorate of Health Services, Kampal, Panaji, Goa. Welcome, Dr. Uttam. Dr. Palani Appan, Vice President, the Federation of Obstetrics and Gynecological Society of India. Welcome, Dr. Palani Appan. Dr. Suresh Hana Gawadi, Professor, Department of Pathology, JJM Medical College, Davangere, President, Karnataka Hemophilia Society, Davangere, and former President, Hemophilia Federation India, New Delhi. Welcome, Dr. Suresh.
Thank you.
Dr. Monica Puri, Chief Country Access and Policy Officer, Roche Pharma. Welcome, Dr. Monica. So, I am thrilled to have Dr. Saloni Sadana with me as a part of this panel, and I would like to have her thoughts on hemophilia today. So, please, Dr. Saloni, can we have your thoughts on this topic?
Clots normally, and it's a most common bleeding disorder due to the deficiency of clotting factor 8, and it primarily affects males, and females remain the carriers. It is a blood disorder on which many state governments are working. Government of MP is also working towards hemophilia along with other bleeding disorders like sickle cell anemia also. So in hemophilia, what Government of Madhya Pradesh has done is that we are providing free factors and care to the patients since 2020. And before that, there were only one hemophilia society. Now we have three hemophilia society in Madhya Pradesh. And we have established our hub centers at Medical College Rewa and 8 district hospitals, which are then connected to the spokes for registration of the patients. And for the factors and for the other things, our corporation has done the rate contract also. Right now in Madhya Pradesh, around 1,043 patients are diagnosed with hemophilia, but we expect that the count should be up to 5,000, and the screening for the patients is continuously going on. In every district of ours, we have a dedicated nodal officer for blood disorders, for hemoglobinopathies, and for the hemophilia also. And we always look at the partners also with for working with us in these sectors, and I'm very happy that there are so many partners who work with us on a pro bono basis in the bleeding disorders, including hemophilia. And we have a state line online registry system also, where all diagnosed patients and their details are entered. So the way forward, we are going to train our people, our healthcare staff, for active screening of hemophilia and management also. And we are developing protocols also for this. And since Government of India has now integrated it in the National Sickle Cell Elimination Program along with other bleeding disorders, this entries we are doing at the Government of India level portal also. So all in all, the overall vision of Government of India for hemoglobinopathies, Madhya Pradesh is keeping up with that vision. And in that vision, whatever we have to do for various hemoglobinopathies, including hemophilia, that we are doing. And this Hemophilia Day in 2025, just few days back, our Honorable Governor also inaugurated a very advanced equipment at BMHRC. So these are the humble steps that are being taken by the government of Madhya Pradesh in our steps towards hemophilia. Thank you.
Thank you, ma'am. So my next question goes to Dr. Uttam. From a state health system perspective, what are the current challenges in ensuring consistent access to hemophilia treatment, especially in Tier 2 and rural areas? And how do quality assurance mechanisms play a role in bridging these gaps?
My voice is
Dr.
audible. My
Yes,
voice is audible.
yes.
Okay, yeah. So good afternoon, everybody. I'm Dr. Uttam Desai, State Family Welfare Bureau CMO, Chief Medical Officer. In Goa, we have somewhere around 70 plus patients who have already been detected, and they are all on treatment. We have with us Hemophilia Society. There are two societies. One is Panjim Society, and other one is Goa Hemophilic Society. These societies have been already tagged with these all patients, and all these patients are we almost 20 yeah, so around 30% of these patients have been already on monoclonal antibodies treatment. We give them the preventive monoclonal antibody, and the rest of them are recombinant extended half-life medicine which they are taking. So almost all are on the treatment, and this is being given through state funds. That's our Goa state is sponsoring them with free of cost. Also, their lab test and all those tests which have been doing it is also free of cost, and we do it as and when it is required. So once the patient is detected by either Goa Medical College or our district hospitals, then we test them, we check their factors and all, and then we start on the treatment. And accordingly, we inform the society, the Pendi Hemophilic Society or the Goa Hemophilic Society, either of them, and then the whole treatment starts. They are these societies keep them on the group, and they help them in getting the appointments and other things. But the drugs and everything we give at our Goa Medical College. At the same time, we have in our North Goa District Hospital daycare center, wherein we give the treatment to few of the patients, so that it is nearer to their house, so that they don't have to travel all the way to the Goa Medical College. Uh, yeah, in near future also we'll be starting this in our South Goa District Hospital daycare center, wherein those from the South District also will able to take the treatment, whatever at the nearer to their house. That is my.
Good to know, sir, your initiatives. So my next question would be to Dr. Palani Appan. Given this year's theme as access for all, women and girls bleed too, How can gynecological and obstetric practices play a stronger role in the early identification and management of bleeding disorders in women? And what are the existing barriers and how can they be addressed at community and PHC level?
Good afternoon, one and all. I'm extremely happy for being a part of this particular program representing Foxy as the Vice President. And the question given to me is how can we gynecologists help you people do, and of course, the society? The answer is very different in the sense we don't see a bleeding patient coming to us with a bleeding diagnosis. They go to a general physician and then they come to us. The challenge which the obstetrician will see is that we may see a case of anemia complicating pregnancy, and when we screen them and go ahead and see, oh, the routine method in our obstetric practice is to treat anybody as iron deficiency anemia, I'm sure we will have more intricacies and discussions on that. So when we see a patient of anemia, of course, the first test we do is hemoglobin followed by a peripheral smear. We have pathologists here and we have learned people here who will be able to understand that. So when we do that, we get a peripheral smear typical of iron deficiency anemia. But then at that point of time, I always urge in my conferences, meetings and lectures and everywhere, whichever discussion, that we think in terms of hemophilias and thalassemia and different features like that. So when they have that issue, then we will think in terms of, because they don't present to us as hemophilia and pregnancy, because they will be treated by a physician already. So when they have any other anemia and then a bleeding spot here and there, then that is the time we will think in terms of, so for them to present to us, it will be difficult in pregnancy. This is as far as obstetrics is concerned. As far as gynec is concerned, a patient will present to us initially as puberty menorrhagia, maybe when she's 11 years and 12 years and just having attained puberty, they will come to us and they will present to us as puberty menorrhagia. So we will do the routine, whatever, investigations, hemoglobin, etc., etc., etc. And at that point of time is the best point of time to catch them young for bleeding diagnosis. And we will do a screening test and we will license with that of a physician, hematologist, etc., to screen for hemophilia. And there is no doubt that if there are recommendations from the Voice of Hemophilia, we would be taking it at the Foxy level and making it quite well. And there is no doubt about it. And we would be a part of how to decrease the incidence of hemophilia and, of course, to treat hemophilia in a gynec patient who's going to become pregnant later on when she's 20, 25, whatever period of time, because it's going to be a carrier in the progeny as well. And so we will be playing a major part both in a gynec patient as well as an obstetric patient and the newborn fetus, which is yet to be which is unborn. And so we would be doing screening for all the three patients, I mean the husband, the wife and the baby which is yet to be born. So we would play a major part, and we could put them as guideline or recommendation, whatever we would come to a consensus in this particular point of the meeting. We could put it as a Foxy statement, position statement, or a consensus statement, or whatever, after getting a prior approval from the committee of my people in Foxy. We would go ahead and do that as well. So we would be in hands with you people, and definitely we will try and do how best we can help you.
Right. So I think screening is much required, and especially if we can do it in newborns and those who are, the carriers, if we can carry them and suggest them, to plan their pregnancy. And early detection is the key, of course, and anybody presenting with bleeding spots or anything like that should be screened. Very well said, sir. So, Dr. Suresh, moving on, you being a pathologist, and you are involved with the policy and diagnostics. So how do you see the diagnostic ecosystem evolving in India? Are you equipped to provide timely and accurate diagnosis for all type of bleeding disorders? And what improvements are needed, sir?
Thank you for this opportunity. I am also a person with hemophilia factor 9 deficiency, and this made me determined me to become a doctor and serve for my blood brothers. And in the last nearly 35, 40 years of my experience, so I would like to share some of the challenges posed in the society. So hemophilia, though global incidence is 1 in 10,000, in India itself, there are about 1 lakh hemophilia patients. But unfortunately, at least 25% of them are identified, registered, and receiving treatment. But the challenges here is, in addition to the low level of awareness, the lack of diagnostic facilities, especially the basic coagulation laboratories, are not available in the district level, and this is the major hindrance for identification and diagnosing hemophilia and other even inherited bleeding disorders like Van Willebrand's disease. And my submission is the establishment of these basic coagulation lab in district level hospitals so will help us to identify and diagnose more and more unidentified people with hemophilia. And another thing I would like to emphasize here, though we have 500 plus medical colleges, and the management of hemophilia is not one professional, it is a multidisciplinary approach. And establishment of a comprehensive hemophilia care in medical college is very easy because already the facilities are there. Only thing is relocate and form the team and serve the community. So that's why the comprehensive hemophilia care concept or model for the disorder like rare disorder like hemophilia and inherited bleeding disorder is more emphasized. And another thing is the awareness part, and even the capacity building of medical and paramedical professionals are also emphasized because the in most of the district hospital, by involving the government, the treatment products are available, but the diagnostic facilities are missing, and because of this they cannot there will be delay in the there will be delay in the diagnosis, and delay in the diagnosis leads to complications, especially disability among hemophilia, which can be prevented with the early diagnosis, early treatment, and especially the prophylaxis. The prophylaxis, right now we have episodic treatment, and it has shown us that it fails in preventing the disabilities. That's why the prophylactic treatment of factor concentrates to prevent the bleeding and as well the complications, mainly disabilities. And one more thing is the basic coagulation profile establishing is not a rocket science that can be done in with the willpower of the government, and I appeal for this one to happen. Thank you.
Right, sir. Point well taken. I think if we diagnose it early, we can prevent the disability, especially with the help of prophylaxis, if this can be done, and simple establishment of coagulation, profile in a laboratory, pathologists can diagnose it and prevent the disability. So, Dr. Monica Puri, from an industry and access point standpoint, what are the most pressing affordability and access challenges that still persist in India hemophilia treatment landscape? And how can industry stakeholders work with policymakers to create inclusive access frameworks?
Sure. Thank you for the question. And I think you said it right because most of us, either from industry, government, or a physician or a provider, all of us are here on this webinar to talk about those challenges, right? So having everyone's perspective is what is needed, is the need of the hour. And why I say this is also because that as Dr. Suresh has mentioned, Dr. Palani has mentioned, Dr. Uttam has also mentioned already that most of the patients are not even diagnosed today, and even if they're diagnosed, the challenge is more about the right treatment also. The science has also advanced in many ways when it comes to treating hemophilia A patients and B also now, where we are talking about now as access for all. And in that access for all, the big challenge, even after diagnosis, is about where do I get the right information, the right treatment also. And that is where the role of physicians come in, the role of patient advisory group, they come in to inform, to educate, to impart the right knowledge about the right treatment that these patients can have. And I would not even want to call patients because now with newer advancements in therapy, actually hemophilia A patients can live a life of near normal. which means eventually not even bleeding at all. So, if science is advanced to a level where prophylaxis can even become a norm for hemophilia today, then why shouldn't we do everything to make it possible? And the commitment of the industry here is how do we work along the patient journey pathway to understand what does it mean to get the right treatment at right point in time, which means we need a holistic healthcare proposal to treating hemophilia where patients are empowered to make the right choices about the quality of life they want to have, whether they want to live with zero bleeds versus they want to live with minimal bleeds, or maybe continue to have the conventional factor treatments and continue to bleed and require treatment on demand. So that education empowerment is first thing which I see is a very important linchpin when it comes to treating hemophilia. The second very important aspect where industry also is committed to make it happen is how do we ensure adherence also to the treatment? Because most of the time, these patients have almost believed that bleeding is now part of their life. They can continue to bleed, they can continue to take treatment, and the cycle continues like this, a vicious circle. But you can actually break that cycle. And to make it happen, we need to give multidisciplinary approach to them also. Those who have already got targeted joints, how do we bring them back through physiotherapy also, through prophylactic treatment also, through other modalities also? How do we increase their longevity and their economic effectiveness to the society by giving them the quality of life? And where industry is coming is to by creating that real world evidence that this is possible. And even for governments to understand how much are they really spending in terms of providing treatment to hemophilia patients, especially during emergency bleeds. Sometimes it can go to the amount of many lakhs and crores also to prevent or protect patient from an intracranial bleed. So can there be more efficiencies in the system by looking at all modalities of treatment and making those informed decisions, and eventually making sure that caregivers are also well informed about how to take care of a hemophilia patients? I think these are some of the nuances that I've mentioned where industry along with other important KOLs, like I said, patient advisory group, physicians, government's interventions, we all can come together and make it possible to have a quality of life for hemophilia patients.
Very well said. I believe that not only preventing the disability, and having a multidisciplinary approach, like with the help of prophylaxis, treatment if it is required, and definitely physiotherapy coming to be if the disability sets in, to give a quality of life, everything is involved, and we need to have a multidisciplinary approach. Dr. Uttam, what policy interventions or public private collaborations do you think can significantly strengthen state level hemophilia programs? And can you highlight any successful initiatives from Goa or other states?
Yeah. So thanks for this question, ma'am. It's very important. Basically, here in Goa, we have the societies, the Hemophilia Society. We have two Hemophilia societies, and we have a comprehensive daycare center at Goa Medical College and a daycare center at district hospitals. So what happens is when the patients are detected, most important thing is the patient should know when to go for the doctor, when they should identify what they have, what they, whether that injury what they have caused to them, especially those above maybe around adolescents or adult patients, especially. So they should know and where to go because this factor it is also many times not available at the PHC or down below. So what happens? Let me tell you one experience of mine when I was way back years before. I was posted at one of our periphery rural areas wherein a patient of hemophilia came during the night, maybe around 11:30, saying that he had a big swelling of the knee. And at that point of time, I did not have anything, but for God's sake, the patient came with himself the ampule of factor 8 saying that he knows what is problem with him and he told us that this is the problem and then I would like that injection to be given. So you can imagine in Goa, I mean the the patients know what they have and what is a problem with them, and they are equipped with it. So that is what we should have. The patient should be knowledgeable. If it happens in pediatrics, there's some other story. The parents should know about it. So here we have our societies. They are very competent, good. They are doing also our comprehensive daycare centers in Goa Medical College, both for the adults as well as pediatric, and in our districts are doing a fantastic job. They give a real dedicated service to the patients, and the patients are very happy. And we give the best possible drugs. Our government, especially our health minister and the chief minister, they are very much concerned, and we have the best possible medicines given free of cost to the patients. So I think we should be more identifying the patients, and then we manage them also, and we make them learn also what is the problem, so that they are equipped themselves, so they don't get injured themselves. Try to avoid injuries where their problems can be aggravated, or they can end up in complications and all that. Yeah, that is the story, ma'am.
Right. So I think awareness is the key, and if you
Yeah.
can go and educate them, right, and just how to avoid the injury so that it should not lead to major problems, I think that's a very good step and good initiative, sir. Dr. Pelaniappan, how can national level gynecological associations and federations play a more active role in integrating bleeding disorder awareness and screening into routine women's health program?
Thank you for that question. I thought we could catch them in. See, what we're trying to do is catch women girls at a very younger age and thinking in terms of cancer awareness, AUB awareness, etc. So at that point of time, if we could put in anemia awareness program, and we have a lot of tests, a lot of projects in the Foxy. So we test any woman, any girl child also, and we would do something called as Know Your Numbers, meaning which we have a project called as Know Your Numbers, where a girl after 8-9 years of age, we would enroll them in any of the hospitals and ask their height, weight, their hemoglobin, and blood sugar to be done, and then we keep them their numbers, and this we call it as passport to their health. So when we're doing some with this screening, when we're having a girl who's coming to a medical checkup, obviously she'll be able to tell us to put something across the hemophilia screening also, because hemophilia screening doesn't come all of a sudden, and it will run in families, and they will have prior history, and they'll come to us with something. They may not be taken to us by surprise. So we could use them as one of the screening in the beginning ages itself, 8, 9, whatever, even before they attain puberty. And the girl who comes a little later, obviously she'll have bleeding, and she'll come to us and say that, oh, we've got excessive bleeding.
Right, right, sir. So your initiative, I think I've lost the voice. I think your initiative of know your number, that
Am
includes
I
the
audible?
height, weight, and yes, yes, you're audible. Do you want to add anything, sir?
Yeah, thank you.
All right. So I think know your number is a very good initiative, wherein height, weight, and HP, if this can be measured for women, definitely it helps, and they should know what their HP is, because this is one thing which can easily be screened to catch the anemia early on, and hemophilia being one of the factors. We can definitely
Point of time.
have
Yeah.
early diagnosis and screening at a wider scale. Thank you for your input, sir. Dr. Suresh, what is your vision for strengthening the role of regional hemophilia societies and pathology departments in decentralizing care? How can they better support both diagnosis and long-term management?
Our Hemophilia Federation India vision is hemophilia without disability, children free of pain. To achieve this, the first and foremost, the establishment of basic coagulation lab at nearby places, district level, is crucial to identify not only hemophilia and other inherited bleeding disorders. And the next part is the establishment of comprehensive hemophilia care in at least 50% of the medical colleges in our country. So this will enhance the quality of care and the quality of life of these patients. And the one more thing I would like to emphasize is the hemophilia. In hemophilia, the disability is preventable. And now, in view of availability of advanced treatment products, extended of life factor, the non-factor therapy, it is better to put the children at least on these therapies so that they go to school, they go to colleges and achieve good education. And good education, definitely, they will be placed in the gainful job, and that increases the quality of life of the not only patient, even in the family. And one more thing I would like to express here is, though hemophilia is included under Disability Act in 2016, but we are denied of the reservation in the jobs. But as I mentioned, we only lack clotting protein in the blood, and we are capable and can compete in the community in achieving education and achieving good gainful jobs if conducive atmosphere is created. It is the government's responsibility to see that prophylactic treatment is made available widely. Many of our hemophilia children, hemophilia youths can get proper education. And even I have an example. Even I can give my example. Though in my days nothing was available, but even then I could become a doctor. I could be now working as a professor in the Department of Pathology, and also recently I am awarded with the Shrestha Divyang Award on the occasion of World Disability Day from the President of India. So that's why we are capable, and only request is to include hemophilia also under the Act for job reservations. And yes, the as it is evident, so we all have to work together and see that the change in the scenario of hemophilia care occurs in the country, and our people also become productive citizens, dignified citizens, and they can also contribute the growth of the nation.
Definitely, sir. I think they should be given jobs and they have to make their future secure as well. And definitely that can help in growth of the nation as well. So, Dr. Monica, how do you foresee pharma innovation and policy advocacy aligning to create value-based care models for rare disease treatment in India? And what role can real-world data and patient registries play in enabling this?
Very pertinent question. And first of all, I want to thank Dr. Suresh for saying this, that these patients should get what they deserve in terms of economy, also in terms of their contribution to the society in a realistic way. See, it's very important that first of all, we understand the value for that patient. Like I said, most of the time we are always seeing this from a perspective of a treating doctor, that someone is bleeding, I will give factors, I will stop bleeding, patient gets all right, he goes home. But when there is a value that you can add to that patient in terms of what does it mean to him to lead a life of disability, to lead a life with hemophilia, and at the same time, he can be provided a prophylactic treatment to not even see a disability. So that actual value is the value that the patient has to put to his life to say this is a valuable treatment for me. Similarly, what is the value for the society here? Because for society, the economic outcome is very important. If our population, which is a young population, is becoming disabled because of hemophilia related disabilities, which are today preventable, then this is the opportunity cost as a society we are losing. So that's the value to the society that we need to inculcate. And third is the value to the provider for any company, for any organization or any government which is putting in money and R&D to get a newer innovation to come in. If we have enough money in the system, all of us can put that money and bring innovation. But unfortunately, we don't have. So someone needs to invest. And if someone needs to invest, he continues need to invest, and that is why he needs a corpus. So that is a value to the provider. And only when you bring these three aspects together, value for a patient, value for a society, and value for a provider, is that when you get the actual value of a treatment for a particular disease. And this can only happen when we have enough data to support it. Now, where is this data coming from? The data is going to come from actual doctors who are treating these patients and who are capturing the progression or the advancement or the betterment of a patient in terms of, if I am bringing it a new therapy, is this new therapy helping to better a life of a patient from what it used to be 10 years ago or 20 years ago? And that is where the real world evidence comes in, which means how much of annualized blood bleeding rate has gone down, how has the disability gone down, how is the patient's life becoming more productive, how much money I'm spending less now in my budget to get a better cost effective treatment. And that is where real world evidence is needed. And this can only happen if we have a very robust evaluation matrix to find the real cost of a treatment in terms of the value. So what pharma industry or the academic institutions or doctors can do together is to really bring the value of innovation out and add the right cost to that therapy in terms of what is it going to be the value for the patient, society, and provider. And that is why we need a very robust health technology assessment with the right state of art frameworks which are being used across the world to get the right value for the treatment. So I think that's where the expertise, the academic knowledge, and the best practices that industry can support with and facilitating this for government, for patient groups and providers.
Very well said. And I think that is why the registries are very important so that we can catch the real world data
Actual
and
number of
get,
patients, yeah.
yes, and get the information out of it so that future can be decided and newer innovations not only in the diagnostic sector but I think the therapeutic sector as well, you know, should come into being so that disability and a good life, disability should not happen and a good life should be there. So, Dr. Palaniappan, I would like to ask you that why might mild hemophilia cases be missed during routine blood testing, and what can be done so that this should not? Yes, sir. So please unmute yourself. Do you want to
You're
take
able
the
to hear me?
physical?
I'm not able to hear you.
Right, sir. All right. So my question is, sir, in your view, why might mild hemophilia cases be missed, and what can be done so that this should not happen?
I think there's a network issue.
Yes. Sir, can you hear me?
Yeah.
All right. So, Dr. Suresh, can you tell me that
Yeah.
how is carrier status for hemophilia determined in female, and how can we catch mild hemophilia early?
Yeah. Actually, Dr. Palaniappan was supposed to take these kind of questions, but since it's a network issue, I would like to share the what are the easiest way or simple way where we can detect women with bleeding disorders. As this year's theme is women and girls bleed too. Actually, the in hemophilia families, we thought only male with hemophilia are sufferers. But women, though there are carrier women whose factor level is subnormal, they may not suffer routine challenges, but definitely they are more prone for bleeding episodes like heavy menstrual bleed, And also when they are posted for certain surgeries, especially the hysterectomy, bleeding will never stop. So that's why it is also important for obstetrician and gynecologists to take history. And if there is a history of hemophilia son in the family, and the mother during surgery, we have to take, including the replacement therapy with the appropriate factor. That is one. And also, as sir was telling, the puberty menorrhagia, and 5% of puberty menorrhagia girls will be having Van Willebrand's disease. This is confirmed with the various studies, and we should also keep in mind, especially obstetrician and gynecologist, while evaluating puberty menorrhagia as one of the differential diagnoses Van Willebrand's disease, and even certain other bleeding disorders like Glanzmann's thrombocythemia, or rare factor deficiency like afibrinogenemia and factor 13. And yes, how to, in a simple way, how to screen for. So actually, clinically, doctor knows well, there is a system called the BAT, that is bleeding assessment tool. And these bleeding assessment tool should be oriented among our interns and our postgraduates to take a detailed history and categorize and try to suspect the inherited bleeding disorder among women by BAT test, BAT questionnaire. And the second one is simple test like prothrombin time and activated partial thromboplastin time should be advised. And it is obvious that isolated prolongation of APTT is a classical feature in Van Willebrand's disease. Of course, if they do bleeding time, if it is prolonged, almost they are with the diagnosis. And one more thing I want to emphasize here: while treating Van Willebrand disease patients, the doctor should also keep in mind the product they use. So in general, earlier we used to use anti-hemophilic factors in general, but because of the technology and the purification process they are subjected, the Van Willebrand factor will be destroyed in the product, and it is devoid of Van Willebrand factor. And many doctors are not aware, and they give this AHF only and achieve no hemostasis. Instead, they should prefer the intermediate purity factor, or the factor which is not subjected to purification process. This point I wanted to highlight, which is commonly I've seen a lot of instances where AHF is used but without achieving any hemostasis. And one more question you asked, no? Can you just
Right. Yeah.
anything else?
So I just want that mild hemophilia should not be missed, and definitely you have told us that even if there is a puberty menorrhagia, it can be one of the causes, and definitely the questionnaires can help, and PT, APTT, these are the simple tests which can be carried out. These were definitely the crux of my question. And if you want to anything, sir, add anything,
And
please go
also,
ahead.
see, setting up of a coagulation profile with routine PT and APTT for all surgically posted patients, because including mild hemophilia, the routinely done in most of the hospitals, that is BTCT, we miss the diagnosis, because in mild
Yeah.
hemophilia and including carriers, clotting time remains normal. And believing this, if they take for surgery, then on OT table, patients' bleeding becomes uncontrollable. Instead of bleeding time and clotting time, let us advocate for the most sensitive tests like prothrombin time and activated partial thromboplastin time, so that we will suspect. Even borderline prolongation will help us to evaluate further and prevent bleeding during the surgery.
Point well taken, sir. So these are the tests which should be included. I think PT, APTT, they are doable, and if they can help us catch mild hemophilia cases, especially something bad should not happen on OT table. So this can be done, and it can be applied in our routine routine practice. So, Dr. Uttam, what key components should be included in hemophilia policy, do you think, to ensure comprehensive and equitable care for every patient?
Madam, yeah. So in this policy, it should be that all those patients should be diagnosed, and active search should be done in the community so that no one is left of being diagnosed who are hemophilic or having a blood disorder. So that's one thing should be there. Then second thing, once they are diagnosed, there should be a proper SOP how they are going to be tested, at the same time to be managed. And the third thing will be their continuations. If they have some complications, how to handle that. All this should come in the policy for the things, ma'am. So and again, the health education to be given to the patients or the beneficiaries so that they are also equipped with something, so that their complications once they get injured are not happen, so that their injuries are otherwise what happens if they get injured and then they delay it and last minute they run around, then it becomes a difficult and those complications do occur. So at the earliest, if they could go to the nearest available health center or the district hospital, wherever it is nearest, and if they get the full treatment, then the injury is limited to that. So that's one thing it should be done, so that their traveling time also is to be taken care of. And what happens, these patients require constant injections. So if we could give them the latest treatment available in the uh, available, that will be much better than going to the basic factor 8, which is now almost getting I mean nobody is using. So, and it also develops their inhibitions and all those things. So yeah, that is it, ma'am.
Right. Dr. Palaniappan, are you there? Can you hear me, sir?
Yeah, very much there, very much there.
Sir, I want some policy, inputs which can be included for to support carrier screening, genetic counseling, reproductive choices from your end, sir.
Right. What we can do is we will get in touch with the Foxy office as well and involve them also. And we will write a policy. We'll be happy to be collaborated with you people so that if you could write a policy and we could approve it, or I mean, we could do something mutually, we could do, because it's something quite serious. We can take it at the Foxy level. And when we do it at the Foxy level, we will reach out. The reach out will be much better to enough of girls if you want to screen them at that particular age of 8 or 9 or whatever. And for pregnancy, yes, we'll also be taking part in all the pregnancy activities. And so we would write up a SOP, a plan of action, and then send it across to you. Or if there is any question that you want to ask,
I think it's a very well said point. I think there should be a policy in place for career screening and genetic counseling and to make informed choices during pregnancy. So, Dr. Monica, to wrap up, what is the standard treatment approach for patients with hemophilia, and how are you seeing that newer treatments shaping up?
In my capacity, although I'm a doctor, I would restrict myself from promoting any product or any treatment. But
Yeah.
all I would say is that we are in a very good situation today because the hemophilia treatment landscape has evolved many folds, which means, like I said before, we have options where patients can actually be put on prophylaxis and they almost never bleed. And if these are the kind of therapies which are available, and as you mentioned, available in Goa today, because as Dr. Uttam had mentioned, the health minister himself committed, and every patient in Goa has the prophylactic treatment today available. Many other states have adopted in their state EDLs also. And I think this is the way forward. The only caveat is that where we need to work now is to build momentum, that we need to move beyond conventional therapies. And if there are newer therapies which are available, how do we create that value proposition for governments also? Because as we all know, hemophilia is something which is part of the bleeding disorders under National Health Mission program. So there is money in the system, there is program in the system. All it requires is right scientific information dissemination to make sure that the KOLs, the decision makers who are sitting on making those policy decisions are well aware of these newer therapies. Again, value that is bringing patient society, and at the same time make sure that therapies are available for all and sustainable, because hemophilia is a lifelong treatment. So there is no shortcut today, and be more open towards innovation rather than having a conventional mindset, because you can actually change the life of a patient forever, that he's almost never going to bleed. Then why should he be allowed to bleed? If anyone knows it, if a patient knows it, he will always want to opt for that. So our job as a society, whether as a pharma industry or a doctor or a government, is to work together, come together, have those policies in place. And of course industry is here to support in making those medicines more accessible, more affordable, and available for all. Thank you.
I would like to take closing remarks for any critical steps that think should be included for a better outcome and quality of patients living with hemophilia. So I would start with Dr. Suresh first.
Emphasized on the quality of life. So we lack only clotting protein in the blood. We are capable of in all other aspects, skills and intelligence and everything. And if prophylaxis is made it as a policy for all hemophilia patients in the country, definitely my blood brothers will be protected against disabilities, crippling disabilities, and they can contribute to the growth of the country. And one more point I would like to say here is the women are highly victimized in the family, in the society, because they have carriership. But when in the family or the in-laws will start harassing, you brought hemophilia into our family, and that's why hemophilia patients suffer physically, but our mothers suffer psychologically. And prevention of hemophilia also is equally important, because we want to prevent the birth of these expensive children by establishing carrier detection and prenatal diagnosis. Carrier detect, because all women in the family need not be carriers, so that's why they should be identified specifically, and if they are carriers, then they can be given prenatal diagnosis. Even legally, the termination of pregnancy is allowed if the fetus is having hemophilia gene. So then prevention, of course, we are in the last so many years we are moving from care to now cure also. Recently, there are some encouraging results of gene therapy trial studies, and one day we will see the cure also for our blood brothers. Thank you, madam.
Dr. Palani, can you suggest?
Yeah.
Can you suggest
Yeah, from my side, my only plea would be to, if the Hemophilia Foundation or the Voice of Hemophilia, whomever, if you have a protocol to be followed and you think we will be of help, and definitely it can be submitted at the end of this meeting to me or to the Foxy office. We will see how we could be able to collaborate with you and get it further done. you want us to test whichever in this particular child and this particular girl or screen pregnant women. And if you have a format already in process, it can be given to us, and we would only be happy to take it up along with us and then upgrade it, improvise it, and be of help to you. I'll be happy if you submit the minutes of this meeting or the protocols which you want Foxy to follow. We would be happy to do so.
Dr. Uttam,
Dr. Uttam,
any
any
closing remarks?
closing remarks?
Yes, yeah. As per Dr. Suresh and yeah, other doctors also have said about this. Yeah, same thing. The prenatal diagnosis would help a lot so that we can go whether the baby either she can go about or if it is just a trait, that decision can be taken later by the parents also. So that's one thing. Genetical counseling also will help because we in Goa also we do that. So we are having it in our Goa Medical College. So that also will help us. And another thing is testing the newborn babies also might help here so that we can find a trait or something like that. And accordingly, further we can work on those babies later on. And again, if their parents also can be uh, told to do the genetic counsel, attend the genetic counseling and all those things. So that will help. Yes, ma'am.
Dr. Monica.
Maybe a plea more than my closing remarks that we have learned a lot today. We are in a situation where more than 86% of hemophilic patients are not even diagnosed because 14% is the diagnosed patients that we know. If we have to reach to those 100,000 or 140,000 patients, it's a long battle, long haul. We alone cannot fight it. So we need all of us together, government, industry, patient group, physicians and providers, and let's all of us just come together and make life beyond zero. And I say life beyond zero because I call it zero bleeds. So let's make life beyond zero possible for the hemophilia patients.
So, on that note, I think we need collaboration, and we have, of course, discussed so many points, and there are so many key takeaways. And I think policies should be refined to have a better quality and better diagnostic facilities for all the patients. I thank you all for joining me today in this important discussion. Thank you so much.
Thank you.
Thank you.
Thank you very much.
Thank you.
Thank you very much.